Next, we're going to attempt to connect with Tony DeSisto, also testifying on 112. Mr. DeSisto?
Thank you, Mr. Chairman. I am testifying on behalf of the Rhode Island Association for Justice. We're in support of this bill. And, this bill actually goes into two parts. And the first part is it allows the families of loved ones that are in the nursing home assisted living facilities to stay in touch with their loved ones that are in there, of course, with their consent. And secondly, also, it gives some comfort to the patients, too. I just want to mention one thing. I noted in earlier testimony that there are already electronic monitoring devices in these nursing homes. So it seems to me that to the extent that there's objections to having these electronic monitoring devices under this bill is not something that should be a concern because they're already in there. And this will be at the consent of the residents. Now, the roommate under the bill would have to consent as well. And if the roommate refuses, under this bill, the facility must make a reasonable attempt to accommodate the resident who wants electronic monitoring. I should note that the costs are borne by the resident or their families for the installation at their own expense. And finally, that the facility can't refuse a potential resident or remove a resident because it disagrees with the electronic monitoring. So, to me, this is a good bill. It is good for the residents. It is good for their family members. Sometimes it's tough for the family members to get in and check on, their loved ones that are in these type of facilities. So it's a good bill all around, and I'd be happy to answer any questions you might have.
So, going back to Senator Bell's concern around, now that we have an attorney on the line, his question around misdemeanor to a corporate entity versus some other way to have a effective enforcement.
Correct. I note that the liability criminally goes to the facility. And if you note, it's a $500 fine. I think that's why it's defined as a misdemeanor, and that's the penalty that you have. So I did hear Senator Bell's comments, understand his concern, but the penalty is defined at $500.
Before I get to Senator Bell, I have one other question around what you brought up in communication, which was became much more of an important issue under COVID, is that people lost the ability to visit loved ones in facilities such as assisted living or nursing homes or even hospitals. And so is there a way, if it potentially there were hurdles with different parts of the legislation and it didn't seem possible to resolve them, to separate the issue of communication from surveillance and potentially work on that as an alternative to how expansive the legislation is now, or the separate legislation on removing barriers to preventing some kind of device, whether it either be telephonic or visual, to communicate with a for purposes of communicating with a patient rather than surveilling a patient.
I understand your question, and I think the answer to your question is yes, and I'll say why. Research indicates that other states have passed this type of legislation, and other states are considering it now. And it seemed to me, and I know we're pressed for time, but I think those issues can be addressed in the same fashion as they have in other states with legislation of this nature.
And in those other states, was the intent for communication rather than surveillance, or both?
Yeah, I'm going to say both, but I don't view this as a surveillance a statute. Rather, I think it's just something where there is that type of communication, particularly in these COVID times. And I know we're nearing the end of the pandemic, but this is just something that makes it easier for families to communicate with their loved ones that are in these facilities. One of the decisions that a family oftentimes makes in this is how close is the facility, because it's difficult to get out and visit in today's harried life, putting aside COVID. So I think that your comments about communication are well taken, and I think one of the main thrusts to this type of legislation.
Yeah, so my issue is that the nature of surveillance is very different than the nature of communication. Surveillance, at least my understanding of surveillance, is 24 hours. And it's, it really, there's less control over it, where communication is based on either, a specific timing based on the family or the patient. I
am fairly certain that the needle can be thread on that between the two issues.
Yeah. So I'm wondering if there are too many hurdles
point.
around the surveillance goals of the legislation, whether people could discuss the alternative of having legislation narrowed to communication.
We'll take a look at it.
Okay. Senator Bell still has a question.
Yes, and thank you, Mr. Chairman, for asking most of my question. And I do support the legislation, and I actually do support it with surveillance. But I wanted to understand in more details exactly what it means. And since you are, Mr. DeSisto, one of our state's experts in legislation against corporate entities, what does it mean for a corporate entity to be criminally liable and guilty of a misdemeanor? Does it mean criminal liability for its shareholders or directors? Does that criminal liability get passed on to individuals? Does it mean essentially nothing? It's just a stronger language or important symbol on top of civil violations. What does it mean to hold a corporate entity criminally liable and guilty of a misdemeanor?
Well, Senator, as you know, a corporation has its own entity. It's a standalone type of a thing. I don't subscribe to that thing that you hear that it's a corporation as a person. And I know that Citizens United kind of said that, but I don't subscribe to that myself. But it's a separate entity, and corporations can be held criminally liable for their actions, including in this one. And to your earlier point, to me, rather than saying that it's a civil penalty, the criminal penalty is more set and defined, and allows the entity, the business organization, to know what the penalties are if it fails to comply with the statute. And this is not something that is an outlier. This is something that corporations are subject to criminal liability based on their nature.
Okay, thank you. So that helps me clarify this. So essentially, criminal liability means that it's not an open-ended amount of penalties as it would be under civil liability. It's a simply per violation issue.
That's correct,
and
yes. And I'm sorry.
As if it were a civil penalty, there would be no major legal difference from making it a civil penalty, except that it heightens the seriousness. It's not like we are applying criminal sanctions towards directors or executives or something like that.
That's correct. It would go to the corporation, and the reason it is set out as a misdemeanor is because under the statutes, the penalties for misdemeanors are defined. In this instance, the statute goes even further and narrows down the penalty at a $500 fine for a violation. No more, no less.
Okay. Thank you so much. That really helps me clarify this immensely. And so, yeah, and I think that also helps clarify my other question about the civil liability in 2317.28-10C, where the lack of any definition of civil penalties simply leaves it open-ended to some kind of determination of level of harm or something like that.
That's correct, yes.
Okay. All right. Thank you. That really helps clarify and address these concerns that I had. So I really want to thank you for addressing that question. Thank you so much.
You're welcome.
Senator Paolino had a question?
Thank you, Mr. Chairman. Just a comment while we have him on the line. I wanted to thank our town solicitor, Tony DeSisto, for being here tonight to answer some questions for us, as well as providing his expertise and testimony. Thank you.
Thank you, Senator.
Any other questions for Mr. DeSisto before we move on? Thank you for calling in.
Thank you, Mr. Chairman. Have a good night now.
Yep. There were two people signed up for Senate Bill 168 that we're unable to contact. We can try them later, so we'll move on to testimony related to Senate Bill 302. And the first person interested in testifying on that, this is step therapy, would be Brian Henderson from the Coalition on Rheumatology Organizations. Brian? Brian?
Hello?
You're on with the committee to testify in Senator Gallo's legislation, I believe?
Yes, that's correct. SB 302. Appreciate that, Mr. Chairman. Wanted to thank the members of the committee for the opportunity to testify and certainly share the support of the rheumatology community for SB 302. I help manage state government affairs for the Coalition of State Rheumatology Organizations, which is a physician advocacy organization that's focused primarily on issues that are impacting rheumatologists and their patients. One of those issues that's central to our mission is step therapy, which is the subject of SB 302. I believe some of my peers from the patient advocacy organizations are going to cover how overzealous application of step therapy hurts patient care. So I will share that the rheumatologists certainly concur with that assessment. There is certainly a role for utilization management, but when it becomes so stringent that it displaces the role of physicians and clinical judgment, reform is certainly needed to ensure that individualized care can occur. And SB 302, I think, appropriately rebalances cost containment with timely and appropriate patient care. To be respectful of the committee's time, I wanted to specifically address some of the issues concerning the perceived cost of the legislation that have or are typically raised. So at the top, I want to emphasize a couple of important things. That SB 302 still requires prescribers, physicians such as the ones that I represent, to justify their exception request with evidence. It allows insurers to deny a request if the justification provided doesn't actually satisfy the exceptions criteria that are enumerated in the bill. Nor does it do away with step therapy. And it also doesn't interfere with the state's generic substitution laws. In fact, the latter is actually specifically clarified in the text of the legislation. So I would ask the members of the committee to ask whether the arguments made suggesting that the cost of the legislation will be high are congruent with the actual provisions of the bill. I believe they are not, and I think that the empirical evidence strongly suggests that the legislation would not result in runaway cost increases. In my role, I've been very lucky and fortunate enough to work with rheumatologists all over the country on bills that are highly similar to SB 302. Over 20 states have passed legislation similar to SB 302, and in each case, we've heard the same argument, that the legislation will raise costs by millions. Indeed, that the sky may fall on our heads. However, when the premium trends in those states are compared to the premium trends in states without the laws, we've seen no actual meaningful difference. And costs of the magnitude that are suggested by opponents of step therapy reform would certainly have to show up in such a comparison. And that's based on publicly available data that I would be happy to submit to the members for follow-up. This lack of cost increase, I think, also makes a lot of intuitive sense because SB 302 allows prescribers to override a step therapy protocol under specific clinical circumstance when the required drug isn't actually a good fit for the patient. Forcing a patient to take a drug that's not likely to successfully manage their condition will inevitably lead to the undermanagement of disease. And that is itself costly from a monetary and societal perspective, as described by Senator Gallo, and it can cause irreversible disease progression and other downstream consequences that burden the healthcare system. The four scenarios that are detailed in the bill under which a prescriber can actually override the required drug all have sound clinical basis. And so the question is whether an individual patient's clinical circumstances satisfy those scenarios. Nor might I point out that the plans are always preferring less expensive drugs. And in a lot of cases, especially in the biologic space, which are frequently used in rheumatology, plans prefer brand name reference products over a biosimilar product with a lower list price, which I think underscores the point which the bill seeks to address, that formulary construction, step therapy protocol construction, is not always designed with actual deference to the drug with the best data or the best or most appropriate care for a patient with that in mind. So we really need a process in place to ensure that patients can have access to the best or most efficacious care based on their individual clinical circumstances. So I believe firmly that the arguments suggesting that the bill will result in exorbitant costs for Rhode Island are unfounded, and that SB 302 would successfully rebalance cost containment with the doctor-patient relationship. Appreciate the committee's consideration on behalf of the Coalition of State Rheumatology Organizations and would request a positive recommendation for SB 302. Thank you.
Thank you. Are there any questions from the committee for Mr. Henderson? All right, seeing none, thank you so much for calling in. All right, I believe next up we have Corey Chandler from the American Cancer Society Cancer Action Network. Hi, Corey. Are you on with us?
I am.
All right. Go right ahead.
Thanks so much. Good evening, Vice Chair and members of the committee. Thank you for the opportunity to provide testimony this evening. My name is Corey Chandler, and I'm the Government Relations Director here in Rhode Island for the American Cancer Society Cancer Action Network. As many of you already know, ACSCAN supports evidence-based policy and legislative solutions designed to eliminate cancer as a major health problem. First, I just wanted to start by thanking this committee for your past support on this legislation. Senate President Pro Tem Gallo and Brian already explained it well, so I won't reiterate how the process of step therapy works, but I did just want to highlight a few key points as it relates to this bill. So first, the treatment should be based on clinical guidelines developed by independent experts and not on financial benefits. So this bill establishes a basic framework for when it is medically appropriate to exempt patients from step therapy. I think it truly goes without saying that the provider prescribing the medication is best equipped with the patient knowledge to determine an adequate treatment plan, and this would be based on a patient's medical history and success or lack thereof on certain prescription drugs. And this really brings me to my next point, which is that delays in accessing the best course of treatment could have serious consequences. This includes the progression of a chronic disease, lower rates of medication adherence, and increased rates of adverse side effects and outcomes. So I'll share a quick story about one of our volunteers. Unfortunately, she was recently diagnosed with stage 4 metastatic breast cancer. So she actually called me earlier this month and told me that her doctor had prescribed her medication to treat the cancer. And in her case, it would be to prevent further metastases. And this was actually back in the first week of April. So she was subjected to a typical step therapy protocol situation. So her insurance company denied coverage of the medication that her doctor had prescribed her. And as I said, it was to treat her cancer. And they required her to try another medication first. So she did explain to me that her doctor told her, well, not in these exact words, but he had prescribed the initial medication that he prescribed because it's more efficacious in improving prognosis for certain types of disease. And I certainly won't pretend to know all the details, but the medication that he prescribed is related to specific hormone receptors and growth factors. And as I shared, the coverage for the initial medication was denied, and she was told she had to try another medication first. All said and done, it took her over 2 weeks to receive any medication at all. And my point here being that she was diagnosed with stage 4 metastatic breast cancer. This is time wasted that she truly does not have to lose. Every day that she waited, her disease could have been progressing. So we actually spoke several times while she was waiting, and she said to me, I wish I could just see what was happening inside my body. So the step therapy reforms that this bill calls for would ensure that patients in a medical emergency get a response back from their insurer within 24 hours, and for non-emergency situations, a response is received within 72 hours. These are reasonable timelines that are not problematic in the states that have adopted model step therapy legislation. And it's also the timeline that Medicare plans require. So many insurers will actually already be accustomed to this practice. And lastly, I also want to emphasize, I know Brian made this point, but this bill would in no way prohibit insurers from using step therapy. It simply seeks to balance cost containment with patient needs. And you'll also hear from those that oppose this bill that it would cost our state millions of dollars. And Brian did a great job of explaining points about the evidence that shows there's no reason to believe that it would result in increased costs. And in the nature of keeping my testimony brief, I'll refer you to my written testimony for additional studies that make this case. So essentially the point here is that passing this bill will help allow for common sense step therapy to continue while simultaneously minimizing adverse health outcomes. Thank you so much for your time. I'm happy to take any questions that you have.
Thank you. Are there any questions from the committee for this witness? All right, I don't see any. Thanks so much for calling in, Corey.
Thank you.
Okay, next up we have Jonathan Cahill. Hi, Jonathan. You're on with the committee. You can go ahead.
Hi. Hi, thank you so much. Thank you so much for your time this evening. I have been listening to the testimony that came before me, and I want to also voice my support for Senate Bill 302, step therapy reform. My name is Jonathan Cahill. I'm a practicing neurologist. I work and live in Providence. I'm a member of the Board of Trustees for the Greater New England chapter for the National Multiple Sclerosis Society, and the secretary for the Rhode Island Neurological Society. And the two preceding speakers gave good and very nice specifics about the specifics of the bill and how it will help people in Rhode Island. I would like to just highlight a few things from my written testimony just to give you some examples of the effects of step therapy and how they affect individual patients of mine here in Rhode Island. So, for example, when I prescribed last year a medicine called DeSisto for the treatment of pseudobulbar affect, which is a symptom of this patient with ALS, the insurance company did not approve the medication because the patient had not tried and had a poor response to treatment with two other classes of medicines, tricyclic antidepressants and SSRIs. And I just wanted to point out that those medicines that were suggested in the step therapy policy of the insurance company were not appropriate for treating pseudobulbar affect in this patient. I frequently, in seeing patients with multiple sclerosis, prescribe a medicine called ocrelizumab, which has no generic formulation available and was studied in clinical trials as first-line therapy, meaning that it was given to patients right from the beginning of their disease 73% of the time. This drug is frequently denied based on step therapy protocols, requiring patients to try and fail less effective therapies before gaining access to more effective therapies. And as another example, this step therapy policies can be applied to generic medications. I've had a generic medication called carbamazepine denied in favor or suggested by the insurance company to try a medicine that would not be appropriate for treating trigeminal neuralgia. And finally, as I wrote about a little bit in my written testimony, I've had 4 instances in 2021 for patients who are stable on therapy for their multiple sclerosis for more than 5 years, and that medication is now denied, and they are asked to step back to alternative therapies, different therapies for their multiple sclerosis. This is definitely not a good way of practicing, and it's not recommended that people who are stable on medication be required to switch to something in a different class or even in the same class, because they can have worsening of their disease. So I appreciate you taking the time to listen to me and to read through my testimony for additional details. I'd be happy to answer any questions about my experience with step therapy, but I definitely think that a reform of some sort would be of great benefit for people in Rhode Island.
Great. Thank you. Are there any questions from the committee for this witness? All right, I don't see any. Thank you so much for calling in.
Thank you.
All right, I believe next up we have Kristen Stifler from the National Psoriasis Foundation. Hi, Kristen, you're on with the committee. You can go ahead.
Thank you, Vice Chair, members of the Senate Health and Human Services Committee. For the record, my name is Kristen Stifler. I'm the State Government Relations Manager for the National Psoriasis Foundation, which represents 8.3 million Americans and almost 28,000 Rhode Islanders living with psoriatic disease. I'm here today in support of Senate Bill 302, and I would first like to thank Senator Gallo and the Health and Human Services Committee for their continued support for step therapy reform. This bill continues to receive unanimous support from the Senate, and I know that this is the year that Rhode Island will join the over 20 states that have placed common sense guardrails around the practice of step therapy. I know you've heard a lot of overview over the step therapy process, and we know that it is an increasingly common practice utilized by insurance companies and can be detrimental for patients facing chronic, progressive, and complex conditions such as psoriasis and psoriatic arthritis. Step therapy, when it's not medically appropriate, can, as you heard from Corey, can result in delays of weeks, months, or even years before a patient can get the medication originally prescribed by their doctor. I'd like to emphasize that step therapy can be an appropriate utilization management tool. However, it can be particularly difficult to apply towards a complex disease like psoriasis. I think that's why Senate Bill 302 does not ban the practice of step therapy. Instead, it outlines an exceptions process for patients and their doctors to bypass steps that are not medically appropriate for them. When step therapy fails to take into consideration the unique nature of a disease like psoriasis, it can be detrimental for patients and can lead to higher healthcare costs for patients and for the healthcare system as a whole. It can cause disease progression, as you've heard, irreversible damage, and development of comorbid conditions. We know that step therapy already exists as a standard practice for most, if not all, insurance companies. And Senate Bill 302 is not banning that practice of step therapy. It is placing those common sense guardrails and ensuring that the doctor-patient relationship remains at the forefront of treating patients. This bill creates a clear process for providers and patients to request an exception to a step therapy protocol and will ensure that the doctor-patient relationship remains at the core of how medicine is practiced. Senate Bill 302 allows for patients to access the right medicine at the right time. I know you've heard parts about the bill. I think the 3 things that I would like to mention about Senate Bill 302 is that it does break out into 3 separate parts. You've heard that the bill ensures that the step therapy protocols need to be based on widely accepted medical and clinical guidelines, not on cost containment alone. The second part about the bill is that it creates a clear and expeditious process to request a medical exception and require a response from the insurance company. We heard from Corey that it's 72 hours for a non-emergency situation and 24 hours for an emergency situation. And then finally, it provides the certain circumstances for a patient and a provider to request an override of the step therapy protocol. And if those certain conditions are met, then that patient can step through that process. The COVID-19 pandemic has been hard on all Rhode Islanders. However, chronic disease patients, especially those who are immunocompromised, have especially weathered this COVID-19 storm. Even with the trials and tribulations of this pandemic, state legislatures throughout the nation have determined that even with the pandemic ongoing, patients need these common sense guardrails regarding step therapy protocols. 5 states have already passed legislation during the pandemic to ensure that patients are getting the right medicine at the right time. These 5 states are part of the 20-plus states that have acknowledged that these common sense guardrails are truly common sense. I believe that today you'll hear some concerns about Senate Bill 302, but I'm here, as well as you've heard before, that these concerns are really unfounded. A couple that I would like to address that may be brought up today is that doctors are pushing patients to move to brand name drugs. And that is not what this bill is about. That's not what this bill does. This isn't about brand versus generic drugs. Senate Bill 302 ensures patients can access the most appropriate treatment as determined by their doctor. Those can be brand name drugs or they can be generic. As I stated before, in many instances, step therapy is an appropriate utilization management tool. However, if there are circumstances that the doctor feels that the step therapy protocol is not appropriate for the patient, the doctor needs to document why that exception to the step therapy protocol is necessary so the patient can access a different medication that is covered by the health plan's formulary. Your doctor knows best, not the insurance company. And the last issue I think I'd like to address is that Senate Bill 302 is not a coverage mandate. Senate Bill 302 does not provide for open formularies. If the treatment is not on formulary, it's not covered. If the insurance company requires a $10 copay or 20% coinsurance, that cost-sharing requirement will remain the same. Senate Bill 302 removes the administrative burden for providers to help patients manage their chronic diseases. As I conclude my testimony, I would like to reiterate that Senate Bill 302 provides common sense guardrails on the practice of step therapy when it's not medically appropriate. The National Psoriasis Foundation respectfully requests your support for Senate Bill 302, and I really thank you for the opportunity to provide testimony this afternoon.
Thank you for your testimony. Are there any questions from the committee? All right, I don't see any. Thank you so much.
Thank you.
All right, next up we have Robert Marshall from the Rhode Island Developmental Disabilities Council. Hi, Robert. You're on with the Health and Human Services Committee. You can go ahead with your testimony.
Thank you. Thank you to the committee for allowing me to speak to you on behalf of the Rhode Island Developmental Disabilities Council. The council would like to start by thanking Senator Gallo for sponsoring this bill. I'm not going to go into a lot of the explanations of what step therapy is and those things because you've heard that plenty. I've been listening. But I want to just focus on that step therapy can interfere with the physician-patient relationship and cause extended delays and severely impact the quality of life for individuals with intellectual and developmental disabilities, especially those being prescribed drugs to address frequent and severe seizure activity. Senate Bill 302 attempts to resolve these issues. If enacted, it would help to ensure individuals with IDD are able to obtain effective medications in a timely manner and provide continuity of care, as well as avoid unnecessary hospitalizations, disruptions to their daily routines, and impacts on their quality of life. SO 302 would not prohibit step therapy policies completely, but would limit the number of steps an insurer can impose. It does not prohibit the consideration or trial of generic drugs over brand name drugs, but instead establishes clear appeals process and clearly provides circumstances where prescribing physician and the patient can override this. We've heard of mainly with children who are on their parents' insurance who have gone through a step therapy protocol that was a disaster. They ended up on the originally prescribed medication, but it took years and lots of seizures to get there. And then either their parent changed jobs or their employer had to change insurance companies to stay affordable, and the new company insisted on going all the way through that step therapy protocol again because the first one wasn't theirs. And this just, repeated all of the problems with quality of life and interruption to learning and everything else. So we really want you to consider this when considering this bill, and please feel free to contact us if you have any questions. I'd be happy to answer any questions you have now.
Thank you for your testimony. Are there any questions from the committee? All right, I don't see any. Thank you so much.
Thank you. Have a good night.
Thanks, you too. All right, next up we have Stephen Schultz from the Arthritis Foundation. Hi, Stephen. You're on with the committee. You can go ahead with your testimony.
Thank you very much, Vice Chair and members of the Senate Health and Human Services Committee. Thank you very much for the opportunity to testify in support of this very important bill. My name is Stephen Schultz. I'm the Director of State Legislative Affairs for the Arthritis Foundation. In the interest of your time and others listening in for their bills, I'll be very, very short because the rest of the patient and provider members that testified did an amazing job and appreciate their testimony and covered anything that I would be able to testify on. I just appreciate the work that the committee has done on this particular bill in the past, their past support and willingness to work on behalf of the patient and provider group in the state to make step therapy work better and strike that balance between allowing insurers to be able to utilize step therapy, but also ensure that it works best in cases where it's not the right course of action for a patient and lessen the burden on healthcare providers. So appreciate your support of this important bill, and thank you for the time.
Thank you. Are there any questions from the committee? I don't see any. Thanks so much. Okay, that concluded our verbal testimony on 302. So now we're going to move on to Senate Bill 646 from Senator Lawson. And I believe we have Janie Straight on with us next. Hi, Janie. Welcome to the committee. You can go ahead with your testimony on Senate Bill 646.
Terrific. Thank you so very much. I just want to say thank you for allowing me the opportunity to speak with you all today. I wanted to speak in support of this legislation, and I would love to share my story with you of how PANDAS has affected my family and really how it has, quite frankly, changed my family forever. Why this legislation is just so important is because if this had been in place 3 years ago, my family and my son would never have had to go through the horrific journey that we have been through in the past 3 years. So to understand how important this legislation is, I really need you to understand who my son Denver is and who he was before he got sick with PANDAS. Denver is a truly amazing kid. He grew up wanting to play outside all day long. He was happiest when he was spending time in nature. He has hiked more mountains than me, and he loved baseball. He was a pitcher on his Little League team, and he would stand on the mound so proud of himself, striking out batter after batter, and then celebrating with his teammates just like any normal kid would do. And he was so smart. School was very easy for him. He didn't even have to try hard to get an A. And then when Denver was 10, and in 4th grade, he got a strep infection. And then another, and then another. In that winter of 4th grade, he had 5 strep infections. Initially, his pediatrician treated him for the strep, but the strep never went away. And that spring, she decided that he was a carrier for strep, and that strep would always be in his system. So she stopped prescribing the antibiotics that he needed to help him feel better. And once he stopped taking any medicine to treat the strep, that's when I started to see my son slipping away from me. My once happy and funny and energetic child quickly became depressed and withdrawn. He stopped eating meals with us, and in fact, he stopped eating at all sometimes. His throat just hurt too much. Seemingly overnight, he grew terrified to be in school. One day, he just had a panic attack at the bus stop, and that was the first time I had ever seen my son have a panic attack. So I started driving him to school in the mornings, but once we got to the parking lot, he would have another panic attack and not be able to get out of the car. And so I would sit in the parking lot for 2, sometimes 3 hours trying to get him out of the car and not understanding why he couldn't. The vice principal, the school psychologist, the school social worker, and several teachers would all come out to my car and try to help Denver to walk into the building. But he would just sit there, frozen, crying, and shaking. He couldn't speak to tell us what was wrong, and even if he could speak, he didn't even know what was wrong. He just knew that he was terrified to leave my side. And so in 5th grade, he stopped going to school. And I wish that I could tell you that school and panic attacks was the only problem that we had. But Denver developed such severe OCD that there were many days and times when he would stop speaking altogether. He couldn't leave a room without touching the chair 25 times. He developed facial tics and vocal tics. He was scared to leave the house, and he wouldn't leave the house for months on end. So it truly felt like we were prisoners in our own home. Denver, who used to live outside, didn't even feel comfortable going in my own private backyard. And so he would spend every day in bed, not leaving his bed for days on end. My happy, well-adjusted child became so depressed to the point where I worried that he would hurt himself. He was angry. He started regressing in his behavior. Once I was able to get him back into school, his easy A's very quickly became F's. And now he has ADHD and difficulty processing information as well as retaining it. He also now has seizures, which are just incredibly scary to witness in your child. So I've told you a lot of scary symptoms that PANDAS causes, but what I shared with you isn't even everything. There is so much more, and Denver deals with so much more than this on a daily basis. This disease is horrific. It is life-changing. It is debilitating. And I knew I was losing my son. I was watching him slip further and further away from me, and I didn't even know why, and I didn't know how to stop it. So after sharing my story of what Denver has gone through, I really would think that you would be asking me, why didn't I take him to a doctor to get him some help? So let me tell you that part of our story, because that's actually where things get very scary. As horrifying as it was watching my son slip away, what was even more horrifying was trying to get him help from medical doctors. When he first became sick, I called his pediatrician so many times. I described what was happening, how he had stopped going to school, how he couldn't leave the house, the panic attacks. His pediatrician told me that he just needed to see a psychologist, and it really wasn't a medical issue. I even suggested PANDAS, but she refused to consider it. So unfortunately, the wait list for psychologists at the time was 4 months, and I knew that I didn't even have 4 months to wait with Denver. He wasn't going to make it that long. So by an odd twist of fate, or perhaps the grace of God, we found another doctor who was familiar with this disease, and she began treating Denver, and he started to improve. And so for the first time in 2 years, I breathed, and I had hope for the future. And then she abruptly stopped practicing. So we met with her replacement, who flat out told me that he didn't understand the disease, he didn't know how to treat it, and in fact, he wouldn't treat it. He wouldn't even refill the prescriptions that were keeping my son healthy. So that was in September of 2020, so mid-pandemic. So I went on to search and find him another new doctor again. In the past 3 years, my son has had 4 different pediatricians. 2 infectious disease doctors, 2 neurologists, and 3 psychologists. In my search to find him help, I have called 19 different doctors' offices, all the way from Massachusetts to Connecticut and as far away as New Jersey, to just try to find somebody who can help him. I have found doctors that can help him, and they have recommended IVIG, but they won't take insurance because the necessary treatments are not covered by insurance. So the initial consultation to even be seen in the office is $1,500. So this past year, as I was laid off due to COVID, unable to work fully due to distance learning and my son's medical condition, I had no choice but to say no to the treatment that I knew would help my son get better, simply because I could not afford the out-of-pocket cost. I have always had very stable careers and very good insurance throughout my life, and I have certainly paid heavily to have that strong insurance coverage. However, when I needed it most, it would not cover the cost of the treatment that would have saved my son all of this heartache and all of this pain. And quite simply, this just isn't good enough, and I really believe and know that we can do better. No family should ever have to go through what we have gone through. Denver asks me all of the time, "Mommy, why won't my doctors help me feel better? Isn't that their job?" And I quite frankly don't know how to answer him, because yes, that is their job. Denver is 12. He doesn't care about insurance. He just wants to feel better. He wants to play baseball again. He has a list of mountains that he still wants to hike, but he can't do any of that if he doesn't have access to the medicines and the treatments that will help him get there. I hope in sharing our story that you can see the impact of this legislation, and I hope that you do the right thing and pass this legislation so that no more families have to go through what my family has experienced. I thank you all so much for allowing me the opportunity to share my family's story with you.
Are there any questions for Janie? Senator Lawson.
I just wanted to thank Jamie for her testimony and sharing your story, or better yet, your struggle in Denver's. Your advocacy is really powerful. Thank you.
Thank you, Senator.
Senator Valverde also has a question.
Thank you, Chairman. Janie, I'd also like to thank you for calling in and sharing your story. That personal testimony is very powerful. Could you tell us a little bit about what kind of the long-term outlook is for a child like Denver who has been diagnosed with PANS or PANDAS and doesn't get the treatment that they might need?
So that's such a scary question. If they do not get the treatment that they need, in doing my research, to be honest, this becomes such a mental health concern for these children that there are several cases that I have seen where suicide was the ultimate result, unfortunately. They become so depressed, so withdrawn, and it's very difficult for them to feel as if they're not getting any help, really. And I could see that firsthand with Denver, the feeling that nobody is helping me. The way that this disease works is it kind of goes in different flares. So they will have a flare where all of these symptoms are so exasperated, and then if they can get some medication, the symptoms start to die down. The trouble with this, however, is that if you're not treating those flares, the longer a child lives with anxiety, as an adult, they become an adult who has an anxiety disorder. The longer a child lives with OCD and it not being treated, they naturally become an adult who has OCD. So there is hope. There is absolutely hope for these children, but treatment and early detection and available resources is what will save them from having to live this way as an adult.
Right. And if I may follow up another question, what are some of the treatments that are not currently covered for this disorder?
The major treatment that is not covered is the IVIG. That is the one that, from everything I have seen and read and in speaking with doctors, could be one of the strongest cures for children, but it is not covered. Another obstacle is the antibiotics. So one of the beliefs is that one of the stronger ways to treat this is a low-dose, long-term antibiotic. There definitely is hesitation with the doctors in prescribing antibiotics in such a way, but from speaking and talking to them a little bit more, the hesitation seems to be the reluctancy from insurance that they don't want the antibiotic used in that way. So it does seem to be two pieces right there, but that's another option to treat this as well, that low-dose, long-term antibiotic.
All right, thank you.
Thank you.
Any more questions for Janie? I also want to thank you for sharing your personal story.
Thank you very much to all of you for allowing my family's story to be heard.
Thank you. Before we go on to the next caller, Senator Lawson, we want to follow up with you on this bill, as some of the notes we have around it say it might be more appropriate to address this in a different sectional law. So we want to go over whether we change your bill or actually try to have it be more effective in a different sectional law. So we want to review that with you at some point, sooner rather than later.
Okay, thank you, Chairman.
Yep.
Actually, Senator Miller,
Yep.
Senator Lawson mentioned that Senator DeMario had maybe something to contribute to comments on the on PANS and PANDAS, and I see that she's rejoined us.
Okay.
So I was just sorry to put you on the spot, Senator
No, that's good, because
DeMario.
I had to depart for a moment. on that, so
But
that's
if
good.
I was wondering if you had anything, as a professional in the field to add.
Sure. So I apologize. I had to step out to go to another committee briefly, so I'm not exactly sure if there are specific questions that I could address. But, just speaking from the perspective of a mental health care provider, this issue from the mental health care provider community perspective is relatively our understanding of it has really evolved over probably the last 15 years or so, especially. And so I think, as you have probably seen in some of the written testimony and may have heard from some of the testimony, a lot of these issues can present as looking like mental health related issues. And so what we started to see in the provider community is these things that we're presenting like one thing, but we're not responsive to the traditional treatments, whether they be psychopharmacological or different types of therapeutic interventions that typically are best practices for what those things looked like. And so then these trends started to be noticed by parents and by physicians and by mental health care providers as well, who would treat these children, that a lot of times the exacerbation of these symptoms would happen immediately following particularly a diagnosed strep infection. And so this link started to be seen. But because for the last, 10 or 15 years, as our understanding of this has evolved, you have kind of this issue that has a biological basis or physiological basis, but a kind of social, emotional, behavioral presentation. And so both the treatment and also looking at the diagnostic coding of this issue has been difficult because it kind of lives in both of those worlds. And so understanding of this has evolved. But in the meantime, parents and children, and especially their treating physicians, have really come to understand the reality of what this is and also what helps. And so the idea of cyclical antibiotic treatments have been used with some good effect. But as we all know, using antibiotics very frequently or for a long duration of time is not good for a number of reasons. And so different types of therapies have evolved, including, as Senator Lawson specified in her legislation, the IVIG treatment, which has really been life-changing for a lot of patients. So basically, it's the situation where, parents understand what's going on with their children. They see, kind of this pattern that's emerging. Their physicians understand these treatments and therapies are emerging that we know help, but the kind of coding and administrative part hasn't caught up quite yet. Although, as Senator Lawson referenced earlier, they're just about to get there. And so, parents have really just been stuck in this loophole of, again, knowing what things would help, but not having their health insurance and having doctors that want to prescribe that treatment, but not having health insurance be able to cover it. So if there are any other specific questions, I'd be happy to answer them, but just kind of from what I've seen in the field for the last 15 or 20 years, that's kind of been the perspective of our community.
So over that period of time, has testing for strep become protocol on trying to diagnose those who show with certain psychiatric symptoms?
So a lot of it is really kind of done typically more in terms of patient history and then in monitoring. So for example, once this understanding started to emerge, basically parents would just try to keep their kids from getting a strep infection at all costs or getting sick at all costs, because they would see that, there was a sickness that would come and then these behavioral symptoms would happen. And so I think, we can draw the comparison about some of the measures we've all been taking for the last year about trying to avoid illness. And so, that connection was seen, and so they would try to take those steps. And I think that now, although I'm not a physician, so I think that question would probably be better suited for a physician in terms of if that is part of the regular protocol is to regularly test. I think it's difficult with strep infections because to a certain extent strep infections can live in our bodies for a long time and can present they kind of present at different times more strongly. So I think that's a little bit of a tricky issue.
So there's not a protocol that has changed about testing or anything when somebody presents with something that is assumed psychological that might have.
I understand your question. Yeah, so I think typically it is unfortunately, or has been more of a trial and error type of thing. So again, a lot of times parents would seek some type of mental health treatment for their child. And, kind of it relates to one of the other bills we were hearing tonight, when those best, standard of care treatments failed, and then maybe this cycle was observed over a period of time where the symptoms subsided and then came back again, that common denominator of the illness link, and then sort of seeing more over time what was going on with that client or patient would be the diagnostic information that would then have parents seek medical treatment or medical advice from a doctor about this instead of or in addition to mental health treatment.
Thank you. Are there any other questions for our expert on this issue?
I do not want to present myself as an expert on this issue.
But it was really valuable, and I think it's something, that perspective is something we want to look at the same time we look at whether there's a better sectional law to address the legislation also. If not, we'll move on to William Landry, who I think is testifying on 709. Mr. Landry?
Yes.
Go right ahead.
Yeah, thank you. Good evening, Mr. Chair. My name's William Landry. I'm a partner with Blish and Kavanaugh in Providence, and I've been outside counsel for Delta Dental of Rhode Island since 1993, and I appreciate the opportunity to comment on this bill. I think that the committee may be underappreciating by a wide margin how much dental insurance is in fact regulated, just like medical insurance. Delta Dental is very much under the control of OHIC and various statutes that cover the same issues that the senator is trying to address in this bill, just covering them different way. For example, on the prompt payment of claims, it was suggested that dental insurers can make the dentist wait a year to pay claims, but there's no time in which the company has to actually pay. Well, Delta actually gives the dentist a year to submit a claim, but we're subject to the Prompt Pay Act, which we supported, where we have to pay claims within 40 days. The bill requests that dental insurers be required to pay within 4 months, but it's 40 days for a paper claim and 30 days for an electronic claim. We have to provide quarterly reports of all of the payments that took longer than those time frames and pay 12% interest, 12% for on every claim that is paid longer than that time frame. So there's very rigorous controls that this bill, if passed, would actually erode by having two side-by-side pieces of legislation, one of which is much less onerous than the existing one. That also exists with respect to the other time frames sought in the bill for payment of claims and pre-authorizations. The bill seeks 60 days for pre-authorization responses, when in fact the statute that Delta's subject to and other insurers, health insurance, the Benefit Determination and Utilization Review Act that the legislature completely overhauled in 2017, only gives us 15 days, which is fine. We supported that bill, 15 days to respond to pre-authorizations and 30 days to respond to post-service claims. This bill would seek to impose a requirement of 4 months, much, much less favorable to the patient than what is existing under the existing law. So I think the bill really should be evaluated for unintended consequences where you have this redundant type of legislation, particularly when it proposes kind of a worse position than already exists, which is a very good situation. The Utilization Review and Benefit Determination Act is dozens of pages long, has all manner of deadlines for dental insurance companies to deal with these issues. On the COVID response issue, that really has been managed very effectively. Delta was one of the leaders in the state. The total budget expended for some type of COVID relief was $26 million, and that included premium rebates for our customers who didn't use their benefits during the pandemic. A 30% premium credit for 3 full months premiums. For individual consumer clients, a full month's free premium. We were able to provide substantial premium rebates to 2,000 groups, 100,000 subscribers, and 185,000 members. That totaled about 4 times as much as Delta Dental's entire net profit last year on its operations, on its dental operations. So they were leaders in this effort to roll over the unused benefits based on the pandemic would effectively be a windfall to the members who have already been fully reimbursed. It would be double reimbursement. And I am aware that Blue Cross Dental and other responsible dental insurers did the same thing with very generous premium rebates, all under the supervision of OHIC, because we had to file rate filings to be able to make those benefits and basically charge our customers less than our rate filings permitted. So, we respectfully suggest that this legislation is really not necessary. With respect to not being able to have deductibles for preventive services, we don't have deductibles for preventive services right now, but we also don't choose which benefits the customers want to have. There may be some people who could only afford a dental plan at a certain level if it were to be without deductibles. That level could not be attained, and that would mean lesser access and more costs for everybody else. So we try to have a very, very broad menu of available options for groups and consumers to choose what works best for their particular situation. We don't force benefits on anybody, and I'm not aware of other dental insurers doing that. So I do appreciate the committee's interest in these issues. I think the committee will find that they're very, very robustly regulated under existing conditions, and that this legislation would make for kind of a confusing morass to have another layer superimposed on what's already existing. So thank you. I'm happy to answer any questions that you might have.
Any questions from the committee? Thank you for calling in.
Hey, thank you, Mr. Chair.
Yep. Next person we're going to try to get on the line is Andrew DiLoretto from the American Heart Association on Bill number 712. Mr. DiLoretto?
Yes.
Go right ahead.
Okay, thank you, Mr. Chairman and members of the committee. My name is Andy DiLoretto, and I am from Westerly. I am a volunteer for the American Heart Association, where I serve on the Rhode Island Advocacy Committee. I'd like to ask you to please allow me to provide some of my medical history, a little snapshot. My introduction to medical care beyond the normal annual physical began in college when I was diagnosed with an autoimmune disorder, which set me on a course of regular doctor visits and prescription meds through my 20s. In 2006, I was diagnosed with valve disease, which led me to open heart surgery in 2008. Following the heart surgery, I suffered 2 strokes, one in 2009 and the next one in 2011. The testing with numerous specialists seemed endless, along with all of the treatment, and at no doubt was very, very costly. All told, despite what I consider to be an active, normal lifestyle for a 54-year-old, I spend a good deal of time with ongoing medical care and medications, etc., more than I ever could have imagined. Ironically, I come to all of you today as one of the lucky ones, as having had access to quality medical coverage. But so many others are not as fortunate, and no one raises their hand to have these challenges. It is vital that we always protect Rhode Islanders battling serious and chronic medical conditions by prohibiting annual and lifetime limits on coverage for essential benefits. I want to thank the committee for the steps you've already taken to codify the Affordable Care Act's patient protections in state law. I hope you will continue that work and support Senate Bill 712. It is so important for Rhode Islanders like me and everyone else. I want to thank you for your time and your consideration this evening.
Thank you for calling in. Any questions for Andrew from the committee? Thank you very much.
Thank you. Have a great night.
Next, we're going to try to connect with Bethany Engstrom. Bethany?
Hi. Yep, I'm here.
Yeah, I believe you work with the American Cancer Society and the Cancer Action
Yes, I do.
Network, and you wish to testify on 712.
Yes.
Go right ahead.
Okay, well, good evening. My name is Bethany Engstrom. I am a volunteer with the American Cancer Society Cancer Action Network. I'm here to share my story on behalf of those with cancer and pre-existing medical conditions and why I am prohibiting the annual limits and lifetime dollar caps on essential health insurance coverages, especially for those of us that need it the most. If you speak with anyone that has been diagnosed with cancer or been told they have an increased chance of being diagnosed with cancer due to a genetic mutation, it's inevitable. They will tell you just how expensive that diagnosis is. Cancer requires continual surveillance and monitoring, including chemo, radiation. It is without a doubt an extreme difficult time emotionally, physically, and also financially. I was only 22 years old, a pre-med graduate from the University of Rhode Island, and was familiar with the word cancer, but little did I know I'd be learning so much more once I graduated. As a young woman at the age of 25, I had already underwent 3 breast lumpectomies for precancerous cells, and after becoming severely ill right before my second lumpectomy, I had a colonoscopy revealing precancerous cells in my colon. Following an extensive workup with my genetic counselor, I found out I have a rare genetic mutation called MUTYH. This drastically increases my chances of being diagnosed with breast and colon cancer at a much younger age than quote-unquote normal. 2 years ago, I made the tough decision to undergo a prophylactic double mastectomy. I knew I needed to take action and kill the cancer before it killed me. The anxiety of knowing one day the results were going to come back positive for breast cancer was taking over my life, and I honestly felt like I could not live like a 20-something normal year old. My procedure that I took over 2 years ago, it reduced my chances of breast cancer by nearly 95%, which is insane. My mom had breast cancer, so this was something that I was doing to help my family. I was hoping that, however, my increased odds of getting colon cancer was still going to be there no matter what. So what did I do? I had regular follow-ups and colonoscopies every 4 years to screen for and remove precancerous polyps, and I'll have to do that for the rest of my life. Amongst all of this, I do know one thing, though. I know that if not for the current protections preventing limits on lifetime and annual caps, the anxiety of remaining cancer-free, compounded by financial instability and the insurmountable debt, it would be devastating to me. And I'm paying off my student loans to the University of Rhode Island, so there we are. However, the legislation before us is not about me. It's about the 374,000 Rhode Islanders that had a lifetime limit on their insurance prior to the Affordable Care Act, and they could see that again. The General Assembly is uniquely positioned to protect both the health and financial well-being of these individuals and ensure that Rhode Island continues to be a leader in access to quality care. That is why I'm asking for your support in this bill tonight, and that is why I'm sharing my story with you in hopes that you will also share yours and protect this bill with me. Thank you very much.
Any questions for Bethany from the committee? Thank you for calling in.
Thank you. I hope you have a nice night.
You too. Next, I believe, Karen Malcolm. Karen?
Yes, hello, Senator.
Thank you for joining us. I believe you were calling in on 712.
Yes, I am Karen Malcolm. I'm calling on behalf of the Protect Our Healthcare Coalition in support of Senator Goodwin's bill 712. We appreciate the committee's time. It's a long evening, and we also appreciate Senator Goodwin for bringing this very important bill forward. You all have done such excellent work in passing the other component pieces of the effort to safeguard patient protections of the Affordable Care Act and state law, and that's terrific. Without this particular bill, which simply codifies the protections that prevent insurers from imposing annual and lifetime caps, the other components, integrated components, can become moot for people. As you've heard from both Andy and Bethany, those folks who are coming up against a particularly expensive health event can in fact lose their coverage for life-saving care that they need. And it isn't only about cancer and heart disease. It's about chronic and persistent mental illness. It's for people who end up in a severe accident of some kind, or very young, incredibly sick children, as we've heard about in other testimony tonight. 374,000 Rhode Islanders benefit from the prohibition, and that's critically important. 89,000 of those are children. Banning the limits has also been shown to potentially save or known to save Medicaid money. Prior to the Affordable Care Act, when patients lost their coverage for a life-threatening disease, they put themselves into poverty or were put into poverty by healthcare costs and often ended up on Medicaid as a last resort. So this bill will help to strengthen and maintain the integration of all of these important patient protections, and it will make sure that we do not go back to the days when, after paying premiums for years, people could lose coverage simply for needing life-saving care. So we know that those of you on this committee understand this, and we look forward to seeing this bill pass your committee and go to the Senate floor this year. Appreciate your time, and if there are any questions, I'm happy to try and answer them.
So I just want you to help clarify for people who are listening to the hearing or the senators or reps who are involved in this legislation that, like the legislation that I'm directly involved with on codifying components of the ACA, this bill is also a bill that codifies, that it's existing in the ACA, and so it does not go beyond what we're currently, or what insurance companies are currently required to do.
Exactly. It codifies existing insurance practice that is mandated under the Affordable Care Act. It puts it into our state law so that regardless of what happens at the national level, we could have a Supreme Court decision on the ACA repeal case any day. Rhode Islanders would be protected against this. And it's important that the Affordable Care Act did a very careful job of mandating a very carefully integrated set of patient protections that we all benefit from today under our plans. Leaving one of them out allows significant avenue for manipulation by insurers based on cost. The added piece to this, I think, that I didn't make clear and that should be understood is that 2 years ago, when the state of Rhode Island enacted its own state-based individual mandate, the penalties people pay for not having coverage under that mandate are used by the state to buy something that is called reinsurance. That reinsurance protects the financial stability of insurers for very expensive situations or patients who become very significantly expensive. And so there is protection for insurers in that regard. It doesn't cover that can also reach a limit, but that cushion has been put into place by the state, and that's important to understand, especially in regards to the annual caps and lifetime limits.
So just so people understand, again, I don't want to be ridiculously redundant, but there's no fiscal impact as it's been evaluated all the times it's been introduced because it's codifying existing law.
Exactly. There is no added cost because this is no change to how we are operating within our existing insurance, health insurance marketplace today. So it is a revenue neutral piece of legislation. It simply puts existing practice as it stands today in state law.
Thank you.
Is that clear? Did that?
Yep.
Terrific. I should say that prior to the ACA, one point that I didn't make, nationally, about more than half, about 55% of commercial insurance enrollees experienced or faced lifetime limits. So this was common practice before the Affordable Care Act. Since implementation of the Affordable Care Act, where people have been protected from this, we haven't seen our marketplaces collapse, correct? And
Right.
so I think I think it would be a mistake for us to not move forward in incorporating this piece of the package in our state law, especially since there is no added cost.
Thank you. Any questions for Karen? If not, before we move on to the next call, I want to thank you for calling in. Before we move on to the next call, I've had a couple of senators who say they either have to go to another committee or have other calls they want to go on. Senator Palino, are you still with us? Okay. We want to keep track of our ability to have a quorum for a hold vote on these bills, so if somebody could assist while we're finishing up testimony, we want to make sure we have enough committee members present for a vote after we get through the next few calls. We only have a few left. So with that, and we'll try to make sure we have a quorum if we are losing it before we're finished with about maybe 2 or 3 people. Seamus Durak from Rhode Island Parent Information Network. Seamus,
Hi, good evening.
go right ahead.
All right, good evening, Chairman Miller, members of the Senate Committee on Health and Human Services. My name is Seamus Durak. I'm here today on behalf of RIPEN, the Rhode Island Parent Information Network. For those that don't know us, we operate a health insurance consumer assistance program on behalf of all Rhode Islanders. Thank you for the opportunity to testify tonight in strong support of S712, which would incorporate an important protection from the Federal Affordable Care Act, specifically the prohibition of annual and lifetime limits in health insurance coverage into Rhode Island state law. While the current federal administration has committed to shoring up the Affordable Care Act, including through the recent expansion of tax credits to make coverage more affordable for Americans, the ACA remains under threat through legislation and through pending legal challenges. Rhode Island can protect its own residents by implementing the most important ACA protections into state law, and the Senate has already committed itself to that important work by passing S3, prohibiting gender rating, and S5, establishing guaranteed access to coverage and mandatory coverage of essential healthcare services, among other protections. I want to take a moment tonight to focus on the subject of S712, one of the most important ACA protections, which prohibits annual or lifetime limits on insurance coverage. Before the ACA, some of our most medically fragile family members, neighbors, and friends ran the risk of hitting an annual or lifetime cap on their health insurance benefits. That could be a child born with serious healthcare needs, a spouse with cancer, a parent involved in a bad accident. And once their medical expenses hit a certain threshold, either annually or over the course of their life and enrollment in a specific plan, it was like their health insurance just turned off. Suddenly, they were on the hook for every single one of their bills, no matter how expensive. This frequently meant that these individuals with incredibly severe diagnoses would go without care. And that obviously led to worse healthcare outcomes, sometimes tragic results. The families would face severe economic stress and often eventually resort to Medicaid once their finances were exhausted. The Affordable Care Act made sure that that would never happen again, but if the ACA ever went away, those caps could come right back, along with the tragic results that we would see not infrequently in the days of annual and lifetime limits. You may hear from folks in opposition that health insurance would be cheaper if insurers were allowed to bring these caps back, and that may be true, but in the same way that health insurance would be cheaper if it didn't have to cover anything at all. The Affordable Care Act and its prohibition of annual and lifetime limits were passed based on the proposition that the sickest Americans were those most in need of the protection of health insurance, and it's important that Rhode Islanders retain access to meaningful coverage, even if the ACA were to go away and even if they have a terrible diagnosis or accident. This bill helps ensure that health insurance remains accessible and meaningful in Rhode Island into the future. Thanks so much for the opportunity to testify tonight. Happy to answer any questions.
Any questions for Sean from the committee? Thank you for calling in.
Thank you so much.
Next, I believe we have Dr. Greg Levin. Okay. The next person, and maybe the last person, we'll give a few attempts on some no answers, would be Sean Cornoyer. Mr. Cornoyer?
Yes, hi, good evening. Hi, can you hear me?
Now we can.
Hi, sorry about that. Good evening. I'd like to thank you for allowing me this opportunity to just give my thoughts on this bill that's before you this evening. I just wanted to say that I completely support this bill.
Yeah, I believe you're discussing 793, Senator DePalma's bill.
For the rearray and the minimum wage support.
Yes.
For the nursing facilities?
Yep.
Okay, good. So I just wanted to just say that I do support this bill. I am a long-term care nursing home operator and administrator. My family has been in the business for approximately 60 years, and we would appreciate if the Senate would have this bill passed, as having not had rearrays consistently, as we have had in the law, has become very difficult to operate without. We need that money for electricity, linens, medicine, for paying our staff, and it's very disingenuous and disruptive to our operations when we don't have this increase every year. As our costs increase exponentially, everything goes up, so it becomes more and more difficult to provide the quality that we do with very limited, dwindling resources. And I'd also like to just add that on the minimum wage, I and many of the people in our industry wholeheartedly support every year increasing the minimum wage, because we feel that, and I strongly feel that, everybody that works for us should have a decent living wage, except that every time that the minimum wage is raised in Rhode Island, it becomes more and more difficult for us to meet that goal, as we, unlike many other industries or businesses, we don't have the opportunity to raise our prices. I can't pass that on to my consumers, as the reimbursement that I receive for the services that we provide are dependent on what we are being given from state and federal authorities. So every time a minimum wage is passed and an increase is passed on to us, that money has to come from other resources, and unfortunately other resources means limiting the amount of labor that we can employ, maybe not having our bills paid in a timely manner. We have to stretch things out, so it becomes very, very difficult to maintain the operations in a fiscal responsible manner. So I would appreciate having this bill go forward. We completely support it, and I am very, 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 very thankful for the people that put this bill forward and did sponsor it. I can't thank you enough for the support, and I do appreciate it.
Any questions for Ms. Cornoyer from the committee?
More than happy to answer anything.
I don't think there are. I want to thank you for calling in, though.
I really appreciate you taking my call, and again, we appreciate this bill very, very much. And for everybody listening, because we want to do the right thing. It's just that we need the help that we've been promised, and unfortunately, year after year, we have not had forthcoming to us, and it's really at a breaking point for a lot of the facilities to continue to operate with increased expenses and, quite frankly, a diminishing return on the money that we receive. So anything we can do, we would appreciate it.
Well, thank you. I think you're our last caller, so I want to thank you for hanging in there as long as you did.
Oh my gosh, no, that's fine. In fact, I mean, I appreciate you guys calling me. It's always a pleasure to be able to participate and to have my voice heard. Like I said, my family's been at this for about 60 years. I'm a third, almost a fourth generation owner. female run facility, and it's getting to be a struggle. So I do appreciate any help that we can get.
Thank you.
All right, you guys have a nice evening, and it's pouring out there, so make sure you have your umbrellas when you leave.
Okay. I don't. Okay, thank you.
Uh-oh. All right, well, you...
So we're going to just take a moment to check to make sure that there are no calls that have been left open, and then we'll, if I can ask the committee members to hold tight for a minute or two while we make sure we've been thorough on that, and then we have some bills for a motion. So I want to try to get the full calendar in for a vote of, to hold these bills. So there's a motion to hold Senate Bill 168, Senate Bill 302, Senate Bill 304, Senate Bill 485, Senate Bill 643, Senate Bill 644, Senate Bill 646, Senate Bill 647, 710, 712, 112, 793, and 380, and 709. Is there a second?
Mr. Chairman, can I request that we separate out the vote for 380 and 644?
Any other requests? So 380 and 644, motion to hold for further study. Is there a second?
Second.
Second by Senator Golden. The clerk can please take the vote.
Senator Miller,
Yes.
Senator Valverde,
Yes.
Senator Lawson,
Yes.
Senator Bell,
And just to clarify, we're voting on 380 and 644, right?
Yes.
Okay, no. Or, sorry, yes. Yes.
Senator Calkin, Senator DeMario,
Yes.
Senator Golden,
Yes.
Senator Palino, we have six.
Okay. A motion to hold 168, 302, 304, 485, 643, 646, 647, 710, 712, 112, 793, and 709. Is there a second?
Second.
From Senator Golden also, there's a second. The clerk can go on those bills?
Senator Miller,
Yes.
Senator Valverde,
Yes.
Senator Lawson,
Yes.
Senator Bell,
No.
Senator Calkin, Senator DeMario,
Yes.
Senator Golden,
Yes.
Senator Palino. We have 5 in the affirmative, 1 in the negative, and 2 absent.
I believe that's all of our business. Is there a motion to adjourn?
So moved.
All those in favor? Thank you.
Aye.
Thank you. I want to thank you all for holding on so long. I believe what we heard was valuable. Senate Health and Human Services adjourned for this session, this meeting. Thank you.